Hi guys, it's Sophie from In the Mess. Today we're going to talk a little bit about oxygen therapy and we'll give you some tips and tricks on how to sort oxygen out for your patients. If one of the nurses comes to tell you that someone's hypoxic, go and see the patient. It's always worth taking a quick history to see if anything's changed, if they've developed any new chest pain or breathlessness, and doing a quick A to E assessment while you're in there. Have a wee listen into your patient's breathing and see if there's anything that might point you towards the cause of their hypoxia, like a new pneumonia. And it's always worth doing an ECG just to check that there's no cardio component causing the breathlessness or the hypoxia, like a massive PE. You probably need to think about some tests like getting a chest x-ray and potentially doing an arterial blood gas if your patient's really hypoxic, but often these can wait a little bit as you need to get your patient stabilised first. In general, we want patients' oxygen levels to be between 94 and 98%, as this is a pretty safe range for most people to sit at. This means that they're delivering enough oxygen to their tissues to carry out aerobic respiration. Below this point, it gets a bit difficult for the haemoglobin to release the oxygen into the cells, and so your patient is probably less stable at oxygen levels below 94%. Between 90 and 94%, the oxygen level is not ideal, but it's probably tolerable if there's other things to focus on in an emergency situation. Less than 90% oxygen sats are bad, so you want to fix that as quickly as you can. In order to fix someone's oxygen level, we're going to put oxygen on. If I am worried about a patient, I will probably start with something like a trauma mask. These are non-rebreather masks. The nice thing about these masks is that the oxygen comes straight into the reservoir bag, fills the reservoir bag up, and then when the patient breathes, they breathe in from the reservoir bag, only taking in oxygen. When they breathe out, the breath escapes through the valves at the side of the mask, and so they don't rebreathe any of the waste gases that they've expired. You need to put non-rebreather masks on at between 10 and 15 litres on the flow meter at the wall. This means that the reservoir bag will fill up quickly enough. Anything less than 10 litres, you're not going to fill the reservoir bag quickly enough for the patient to keep breathing. You're aiming to get your patient's saturations up as quickly as possible, and the non-rebreather mask will help you do that, delivering between 85 and 90% oxygen. Once your patient's sats are between 94 and 98%, you can think about weaning your oxygen back. You can do this in two ways. You can either put on a simple face mask and reduce the oxygen by 2 litres every 10 to 15 minutes based on the patient's sats. So you can just stand at the bedside and see what their sats do on the machine as you turn the oxygen down, trying to put them on the least amount of oxygen to maintain safe sats. The other thing you can do is you can use the Venturi system. So the Venturi systems have a certain amount of oxygen flowing through them, but they've also got holes at the side, and the flow of oxygen through the Venturi device draws in oxygen at the same time. It works on the Bernoulli principle, so you have to put exactly the right amount of oxygen through it to draw in the air to create a precise mix of oxygen. This is actually written on the side of the Venturi devices, so if you look at it and it says this one needs 8 litres per minute, you have to put 8 litres per minute through it. Turning the oxygen up and down on Venturi devices doesn't really work. You don't deliver more oxygen, you're just messing about with physics. Just change the Venturi device to one that's more suitable for the flow of oxygen you want to give. So cut down to the next one if your patient's doing well. A lot of people don't really like wearing a face mask for long periods of time. It's difficult to talk with them on, it's difficult to eat and drink. So if you're down to about 4 to 6 litres of oxygen per minute, you could probably think about switching to nasal cannula instead. They're much more tolerable for patients, but they do sometimes dry out their nasal mucosa, so it might be worth, if they're going to be on oxygen for a little while, putting on a humidifier so that it's more comfortable and tolerable for your patient. Once your patient's able to maintain sats of above 94% on room air, you can take the oxygen off altogether. We don't have to go back to entirely normal sats in order to take the oxygen off. If you're with a patient who's unwell and they have sats that are unsatisfactory, less than 94% or even less than 90%, and you've tried to put on a non-rebreather mask and your patient's sats are not coming up into that 94 to 98% range, you need to get help. That patient is very unwell and they could become unstable very quickly. Call your registrar or your senior to make sure that someone comes to see that patient. That patient may need more intensive therapy in terms of high flow oxygen, high flow nasal cannula, or potentially invasive ventilation. So get them reviewed early and get critical care involved if you're worried. what about people with COPD? Well, in general, most people with COPD actually rely on the hypercapnic drive that the rest of us breathe with. A clue that your patient might rely on hypoxic drive would be if they carry an oxygen alert card or if they can tell you that they have been on NIV for type 2 respiratory failure before. So always remember to ask the patient before you pop them on the oxygen whether or not that's the case. There's a small proportion of people with COPD, about 10%, who rely on a hypoxic drive to breathe. So these are the ones where if we put too much oxygen on them, the oxygen will actually build up in their system, they'll stop remembering to breathe, and then they'll build up carbon dioxide in their system and become acidotic. So it's something for us to worry about, but it's always worth remembering that the hypoxia will kill you before the hypercapnia does. So if you're not sure, put the oxygen on, then when your patient is more stable, take a blood gas and sort it out later. We can always take the oxygen off, wean it down, or in a worst case scenario, go on to NIV if we've ended up removing the hypoxic drive. But the hypoxia will kill them first. So put the oxygen on and sort it out later. So there are some other things that we can do on the ward to support someone's breathing, such as CPAP or NIV, but these are really specialist situations and you really need a senior or a respiratory physician to guide you doing this. So don't be tempted to start someone on that by yourself. Hopefully that's shed a little bit of light on the subject and you'll feel a bit more confident the next time you're facing a hypoxic patient. Don't forget to like and subscribe to our channel so you never miss a thing.